Good morning all. Today I'll be discussing a paper on outcomes of bleb needling with high dose, that is 40 microgram injectable subconjunctival mitomycin in failing or flail blebs. As we all know, trabeculectomy in the age of antifibrotic agents has become much successful. However, the bleb is known to remodel indefinitely and cause scarring. And the rising intraocular pressure associated with failing blebs continues to be an issue long after the glaucoma surgery has been performed. So what are the options we have at this stage? Either introduce AGM or go for a resurgery, that is a trab or tube, which again has lower success rates, or go for a bleb needling. So in Asian population, scarring is one of the main causes of filtration failure. So using an adjunctive antifibrotic agent like mitomycin C along with bleb needling can help to maintain the long-term filtration. So the purpose of our study was to evaluate the outcomes of bleb needling with high dose, that is 40 microgram injectable subconjunctival mitomycin C in failing or failed blebs. So ours was a prospective non-randomized interventional case series which included 52 eyes of 52 consecutive patients who are more than 18 years. The filtration surgery was carried out between 6 weeks and 1 year postoperative period with the failed or failing bleb with raised intraocular pressure requiring anti-glaucoma medications. We excluded any previous surgery, multiple trabeculectomies, and surgery performed more than 1 year. So we performed the procedure in an OR under topical anesthesia. The high dose mitomycin C with lidocaine is injected subconjunctivally 8 to 10 millimeter far away from the bleb area. Then the drug is swiped posteriorly, and then a bent 26 gauge needle is introduced 2 millimeter away from the bleb and advanced beneath and cutting the flap and the fibrosis. The endpoint is set as change in the appearance and the size of the bleb with adequate elevation. The elevation can be noted here. So we used a 40 microgram, that is 0.4 mg per ml, that is mixed with 0.1 ml of this solution is mixed with 0.1 ml of lignocaine. So outcome measures included intraocular pressure, number of anti-glaucoma medications, best corrected visual acuity, and complications. The complete success we defined as IOP more than 5 or less than or equal to 18 without medications, or more than 20% reduction from baseline if the pre-op IOP was less than or equal to 21. Qualified success above criteria with additional AGM, and failure to meet these criteria were considered as failure. So in our study, the glaucoma duration was 2.92 years and the time interval to needling was 6.77 months. So the IOP before needling was 25.56 and the number of AGM before needling was 2.02, and the confidence interval between 18 to 46. So this is the box viscous plot showing the distribution of intraocular pressure over the visits. Here we can see the preoperative intraocular pressure, and at month 12 after the bleb needling, there was a significant reduction in the intraocular pressure. The number of anti-glaucoma medications also significantly reduced from 2.02 to 1.1 at the end of 12 months. The BCVA remained same. The success was overall around 88.3% at the end of 12 months. Coming to the discussion, the needling with mitomycin C seems to be an effective way with an overall success rate we achieved around 88.3% at 1 year. Literature has noted success between 60 to 70%. So this study by Shetty et al. Showed a 64% total success rate. So the point to be noted here is this study, slit lamp needling was done. And one more study which used high dose mitomycin C, 60 microgram they used, and the success was 84.6%. So the studies which use low dose mitomycin C reported lower success rate ranging from 57% of the eyes. So in our study, there were no corneal complication noted because we had initially separated of the mitomycin C injection from needling, which reduces the risk. So to summarize, with a simple procedure of subconjunctival injection of high dose mitomycin C along with bleb needling, it is possible to avoid a second filtration surgery. We can definitely minimize reintroduction of topical anti-glaucoma medications, but however, we need a meticulous technique and strict standard asepsis protocol to ensure minimal complication. To conclude, this inexpensive, safe, and simple intervention is a viable alternative with less surgical trauma compared to resurgeries.
Thank you. Can't we do it in OPD? Because a lot of people are doing the needling in OPD itself.
Yes, sir, we definitely can do in OPD, but then again injecting mitomycin C and the needling, it is better and safer to do in an OR. We get more control and the
Yes, it is
meticulous
safer,
nature of it.
definitely.
Yes.
And there are cases when you can get into certain hypotony also.
Yes, sir. Yes, sir.
You don't feel that there were any of these eyes had persistent epithelial defect or any conjunctival ischemia with the high dose compared to standard dose?
No, madam. This 52 eyes which we actually did, 40 microgram we used. In fact, if you notice the other study which I showed Dr. Vanitha Pathak, 60 microgram. So this is somewhere in between and we didn't notice any corneal complications as such.
Next.
Thank